next up on our program is Dr. Shahla Hosseini, and she's going to talk with us about outpatient rehabilitation, the role of the physiatrist in optimizing function after stroke. She is a board-certified physiatrist at the University of Cincinnati Medical Center who focuses on neurorehabilitation. She specializes in muscle spasticity and gait dysfunction. Thank you for being here, Dr. Hosseini. Please turn on your webcam and begin your talk.
So I'm Dr. Hosseini. I am a physiatrist at UC Health in Westchester primarily, and I'm really excited to speak to you about a little bit about what I do and you know, kind of my approach to treating patients. So I wanted to speak about the role of optimizing function specifically after stroke or aneurysm. And specifically about the role of an outpatient physiatrist, because that's what I am. So I kind of wanted to give an overview before I got started about the kind of talking about the components of the outpatient team. Then I wanted to speak briefly about the symptoms that you might experience after a stroke, and then what impact specifically they have on various functions. And then speak about how the physiatrist may be different in various rehab settings. And then some of the some of the treatment approaches that I use as a physiatrist, specifically with regards to 3 examples that I see very commonly are shoulder pain, muscle spasticity, and difficulty walking or gait impairment. So I don't know how many of you have heard of a physiatrist, but I wanted to tell you a little bit about what it is that we are. We're also known as rehab doctors. We have training in the specialty of physical medicine and rehabilitation. And it's important when you're looking for a physiatrist to look for somebody that has board certification by the American Board of Physical Medicine and Rehabilitation. We have a broad medical expertise to treat disabling conditions. And specifically physiatrists, what kind of really drew me to the specialty way back in medical school was this idea of focusing on individuals' function, right? So there's various other specialties that just treat one disease state and, you know, one specific condition, whether it has, you know, a major impact on function or not. But what really kind of sets physiatry apart is that we're seeing the person as a whole person. We're figuring out, okay, what do you need to get from, you know, point A to point B? What kinds of things are holding you back? And really focusing on treating you as a whole individual and figuring out like kind of more problem solving. So when might you see a physiatrist? So it's possible that you might see a physiatrist during the acute hospitalization for your stroke or aneurysm. Most typically, if a physiatrist is consulted, it's done by the primary team, which usually is neurology or neurosurgery in the case of stroke or aneurysm. And so, you know, they'll ask the physiatrist to see the patient to, for instance, determine what interventions would be most appropriate for rehabilitation. And then they would come and see you as a consultant and then, you know, kind of check on you maybe like a couple times a week, something like that, but not necessarily see you every day unless needed. And then if you end up either in the inpatient rehab setting, which is where you get the more intensive rehab for about 3 hours a day versus a skilled nursing facility, which is a little bit less intense of a rehab program, but can be up to 3 hours a day as well. So in the inpatient rehab setting, usually a physiatrist, but sometimes more of a generalist physician or medicine physician will lead the rehab team, right? So the rehab team consists of the occupational therapist, the physical therapist, the speech therapist, as well as the overseeing physician, right? And so usually that's a physiatrist that's coordinating that care, but then sometimes it can be the generalist physician. And then on certain rehab units, it's actually the physiatrist as a consultant, and so just specifically making recommendations about rehab interventions, whereas the main physician in that case would be managing like your blood pressure and your diabetes. And so there's kind of a combination of different ways that you might see a physiatrist. It is possible, even in inpatient rehab settings, you might not even see a physiatrist depending on where you go and what team you're assigned to, right? So it's possible that many of you have never seen a physiatrist. But I realize that there is definitely value in a physiatrist being a part of care after stroke. So if you end up at a skilled nursing facility, usually it's a generalist physician who is a treating physician and not a physiatrist. Once in a while, again, you might have a physiatrist coming in as a consultant. That's possible, but most often it's like a primary care physician that's managing your blood pressure, your diabetes, and any other medical conditions that you have. And sometimes there's not much of a focus on some of the things that the physiatrist looks for, which I'll speak about later. And then once you get home, oftentimes either the neurologist or sometimes your primary care physician might think to refer you to a physiatrist. And then that's when you can meet somebody like me potentially. Let me advance this. So what are some of the symptoms that you might experience after a stroke? Well, difficulty with vision, right? Dizziness, imbalance, you guys can relate to many of these, I'm sure. Possibly slurred speech, difficulty swallowing, difficulty expressing yourself, which is not necessarily related to how you pronounce the words, but really it's more of a thinking process. Many of you might have heard of aphasia, right? So there's expressive aphasia where we have difficulty expressing our thoughts, right? They're in there, but they can't come out like we want them to. Or there's receptive aphasia where you have difficulty understanding what people are saying to you. And so many patients might experience different forms of aphasia or maybe a combination of both. There's trouble oftentimes with memory or thinking or processing. Weakness is a lot of what I see as a physical medicine and rehab doctor. Numbness, bowel and bladder incontinence, various forms of pain, right? So I'm going to speak about shoulder pain specifically, but there's different kinds of pain. There's musculoskeletal pain where you can feel it in your muscles, your joints, and then there's nerve pain, which is not uncommon after stroke, of course. Depression and anxiety is a huge factor in how people recover after stroke. And a lot of times people will think, well, you're just depressed because you had a stroke, you're feeling down. Well, there's actually chemicals in the brain that can change as well after a stroke. And so a lot of times we find it useful to have patients on antidepressant medicines to improve their functional recovery as well. And then a lot of what I do as a physiatrist is focusing on muscle spasticity. So I'll get referrals specifically to treat muscle spasticity to improve patients' function. So these are some of the symptoms, right, that you might experience, but then what impact does it have on your actual function? This is what's important, right? This is what you guys really care about. It's what I care about too. Your activities of daily living, right? So what are the activities that you're doing, from the time you wake up till the time you sleep, right? You're trying to eat, you're trying to feed yourself if you can. You want to be able to communicate, dress yourself, bathe yourself, toilet, and then go back to sleep, right? And sleep through the night, ideally, right? So these are all the things that we would expect to do in the course of our day to take care of ourselves. And then, we do also care about getting around. And so how are we going to be able to get around? If we need to roll from side to side to maintain our skin integrity, right? We're not supposed to sleep in exactly the same position like the whole night. We need to be able to roll. Transferring to and from our chair, whether it's our wheelchair or the chair at the dinner table. Walking, right? For some of us, we might be able to walk after a stroke. For some of us, we might need a wheelchair. And then it's important, something that I educate patients on a lot is the importance of maintaining skin integrity after becoming immobile, right? So if we're sitting on our bottoms for large hours of the day, your skin is at increased risk for pressure sores and skin breakdown. And so I do a lot of education on how to maintain skin integrity. And then, when we think beyond these very basic things of how to take care of ourselves and move, what's the next step, right? Getting back to work, wanting to drive, take care of our own finances. And these are considered independent activities of daily living, or IADLs, you might hear them referred to. So, when somebody comes to see me for the first time, my approach is to, first of all, listen to what you have to say, right? So what is it that you're really hoping, what troubles are you having? What do you want to be able to accomplish? And so a lot of my questions are kind of oriented around how can I help you to achieve your goals. And so then when I do the physical exam, the things that I focus a lot on are, how is your strength? How is your feeling of your joints moving in space, right? So if somebody has trouble walking, say, it's not necessarily because of only weakness, but sometimes it's because you can't feel where your feet are in space. And so I'm going to want to get a good assessment of that so that I can help you to be able to move better. What kind of range of motion do you have, right? So maybe at your shoulder. Is it at your hand? Can we not get your fingers open to be able to clean in there? Is it a range of motion problem at your ankle, right? So I'm very concerned about range of motion because that impacts function. And then spasticity is a lot of what I do assessment of. So you might feel me, moving your joint in, various speeds. So moving it slower and then moving it kind of faster and kind of assessing the quality of that movement. And then that will give me information about, again, how it's going to impact your function. And then I'll get you up. I want to see if you're able to get up, right? So I want to assess your balance. And what kind of walking ability do you have? How much assistance do you need? These are all things that are important in assessing your function. And then I'll, have a realistic discussion with you, right? So if you say, if you've got no strength on one side and you want to get back to walking, then we'll have a chat about how realistic that is. And my goal is always to improve your level of function and also your quality of life. And then a lot of times, in my therapy assessments and my therapy prescriptions, the emphasis is on getting you to the least restrictive mobility device, right? So for instance, you might be totally safe sitting in a wheelchair, but if you don't need to sit in a wheelchair, let's get you up and using a hemi walker, for instance, or what's the least restrictive assistive device that you need to be able to achieve the goals that you want and be able to get around safely. So one of the common things that I see after stroke is shoulder subluxation. I don't know how many of you are familiar with this term, but you might have seen it. It's where your shoulder kind of sags down on the side that you had your stroke on. And so what's causing that, right? Is it really a dislocation? Some people might refer to it incorrectly as a dislocation. It's not truly a dislocation where where I'll use my little arrow here, where the shoulder joint is all the way out of the socket, but it's just kind of sagging down in the socket. So here, you can see that the shoulder joint is right in the right place, right? So this is a normal shoulder joint. After a stroke, there are muscles here that aren't shown in this specific diagram, but they are shown down here. There are muscles in here, part of your rotator cuff muscles that usually hold your shoulder joint, your shoulder socket, like up where it belongs. And so when those muscles get weak, what happens? It sags down, and that's what you see as that shoulder subluxation. So why is that important? Well, it can cause impingement of the rotator cuff muscles. So one of the rotator, you don't need to pay attention to all the details of all the anatomy, but it is important to know that there's the supraspinatus tendon, which is part of the rotator cuff. This is one that's very commonly impinged, or impinged is basically means like pinched, right? And so it doesn't have enough room to slide back and forth. Usually when you move your shoulder out like this, right, the supraspinatus tendon will be able to slide back and forth in this space. But if your shoulder is pulled down too far, then it's going to get pinched, and that's going to be what causes that pain that you have if somebody else lifts your arm and oh, it hurts right there, right? Or if you're trying to get you dressed, you might find that it's very painful. And so I'm going to speak in the next slide about what the treatments are for that. The other thing that I see commonly causing causing shoulder pain is nerve pain, right? So if you've had like a stroke, affecting your basal ganglia, for instance, you might have, or thalamus specifically, you might have increased nerve pain. And so there are treatments, including oral agents, right? So oral medications. There are topical creams that we can use. And then there's also desensitization by physical therapy and occupational therapy that can sometimes help as well. And then muscle spasticity, that's the bread and butter of what I see. So if you have muscle spasticity at some of those shoulder muscles, like your pectoral muscles, that are making it hard, if it's painful for someone to help get you dressed or clean under your arm, that could be contributing as well. And sometimes it's a combination of all three of these things, right? So I'm trying to sort out which one of the one or two or three of these is impacting your shoulder pain. So how do we treat it? I would say the main thing that I prescribe for shoulder pain is probably physical therapy. It's the main thing that I prescribe for a lot of things as a physiatrist. It's probably one of the things I prescribe the most. But in addition to physical therapy to, strengthen those muscles, right, the rotator cuff muscles that need to hold up that shoulder in place, a lot of times I'll prescribe a brace for walking, which you can see here. This is called the Give More sling. And what's nice is that it allows your arm to kind of swing naturally when you're walking, but in a very supported way. So you can't see it in this picture, but it hooks around kind of the armpit area of the other side of the arm as well. It's a little bit of a challenge to get on at first. Once you get the hang of it, it's not too bad. Obviously, you would need help after having a stroke, and so your caregiver would have to help you with that. Additionally, what gives your arm support if you're sitting in a wheelchair, is this arm trough, right? So you can get an arm trough, or you can even have a tray across your wheelchair. And that's nice because it allows your arm to not sit in a sling. We don't like your arm to be in a sling up against your body because that can lead to all kinds of other shoulder problems like frozen shoulder. But this allows your arm to be supported and away from your body so that you can still, get in there to clean under the arm and whatnot. Kinesiotaping is sometimes used by physical therapists as well. So that would be applied by the physical therapist, and it kind of takes the place of those weak rotator cuff muscles to hold your shoulder up in place. And it can have varying degrees of efficacy depending on who's doing it. So it's really important to get to someone who knows what they're doing for that. I don't find that there's that the shoulder subluxation cuffs are all very effective. You might have heard of those subluxation cuffs. A lot of times they're difficult to put on and then kind of bulky and kind of inhibit your function. But those are sometimes used as well. And then there's oral medicines, various kinds of oral medicines depending on the kind of shoulder pain that you're having. There's creams that can help as well, and then there's injections. So this diagram here shows the approach of a subacromial bursa injection. So this would be in that case of where you have shoulder impingement. That could be helpful. In the case of botulinum toxin injection, that's for if you have muscle spasticity, especially in those pectoral muscles or sometimes the muscles in the back of your arm here. Botox injections can help to kind of like loosen up that muscle and allow you to range it better. So with regards to spasticity in particular, it's really important to figure out, is this muscle spasticity or is this contracture, right? So this can happen at pretty much any joint that is affected by your stroke. So if you have weakness in the muscle, or even if you don't have weakness in the muscle, you can still develop spasticity on that side of the body that's affected. So what's really important to know, as a physiatrist and as, I try and educate a lot of doctors in this area, is that muscle spasticity and contracture are not the same. So I get excited when I see muscle spasticity because I know that I can treat it and it's reversible. Contracture is not so easily reversible and oftentimes requires dynamic stretch bracing, right? So kind of like one of these braces where you crank up the dial on it, and they're not really, sometimes they're painful. They're not well tolerated, I should say, at least. Surgery is sometimes a treatment for contracture that's really bad if it's causing a problem. But muscle spasticity in particular, we see after not only stroke, but we see it after spinal cord injury, anything that affects what we call the upper motor neuron system. So after spinal cord injury, any kind of brain injury, as well as stroke, and then other kinds of neurologic diseases as well. Multiple sclerosis, we see it in as well. And so it's a muscle tightness. You can think of it as that way. It can also cause muscle spasms, right? So muscle spasms are sometimes related to the muscle spasticity as well. So again, when the physiatrist meets with you, they're going to want to discuss goals. We need to set functional goals. And so what are our goals? Is it to improve your function, right? Is it to improve your hand use? Is it to improve your transfers or your walking? Is it to decrease pain? Is it to make hygiene easier? This is a picture of some common patterns that I see with regards to spasticity. So here, the shoulder is kind of like pulled in, right? The elbow is bent, the wrist is bent, the fingers are flexed. Sometimes I see much more flexed fingers as in this diagram. And so if a person comes to me like that, the question is going to be, well, I'm going to figure out how much strength do you have to use the arm. I'm going to try and look at your skin to see how easy is it to get in there to clean. I'm going to talk to your caregivers and ask them, what are you struggling with, right? As well as the patient, you know, like, are you able to get your own arm up and clean under there? Or are you struggling, or is your caregiver struggling to get under there to keep your hand clean? And then if you have, you know, an ankle that's pulling in like this could be, you know, a combination of weakness. It could be as well as spasticity. And a lot of times I see kind of both of those together. And then I'm going to want to figure out, well, which muscles, you know, would I want to treat to help improve your ankle position so that you can walk better and that maybe you can fit into your brace better. If your knee is flexed like this, and why is that a problem if you're not walking? Well, because it can cause skin breakdown, because you're going to have increased pressure over different joints in your body that can lead to skin breakdown. It can also make it hard to, you know, clean behind your knee if your knee is stuck in that position. So I'm going to want to figure out ways to treat that. This just shows a close-up of the hand. And so with each treatment that we consider, we have to figure out, well, what are the risks and benefits? A lot of the oral medications, for instance, cause drowsiness. And so we're going to want to consider, you know, is this appropriate medication? If you're just taking it at night, for instance, maybe it's not a bad thing that you know, that it could cause some drowsiness. So sometimes we like to take advantage of some of those side effects. In other cases, you know, we don't always want to treat spasticity. For instance, if you've got a lot of weakness in a leg, but you've got a very tight and spastic leg, sometimes that muscle tightness can actually substitute for the weakness that you have. And so I'm not going to want to take away all that spasticity. And so that's, again, you know, seeing with the eyes of a physiatrist, you're able to kind of focus on function and realize, like, okay, how much do I want to take away versus let you keep? So that's really important. So some of the treatments that we use, number one is stretching. I always emphasize the importance of stretching along with whatever other treatment we have. So that's usually gentle stretching, right? So if you go really fast and you're trying to, you know, kind of stretch out those fingers, you're going to meet a lot of resistance. And so we want to kind of stretch very, very gently and slowly. And a lot of times I'll show you how to stretch whatever particular joint it is that we're concerned about. And then the physical and occupational therapists can do additional teaching about that, as well as focus their therapies on improving your function. The dynamic stretch splinting I spoke about briefly. Those have like cranks that over time you can kind of increase the joint range of motion. But again, I don't use them a lot unless there's a very severe contracture. Oral medications, there's various classes of oral medications, but a lot of times we're limited by the side effect of drowsiness. And so in those cases where it's not a good fit for oral medication, I'll use focal botulinum toxin injections. Many of you have heard of Botox. We use it therapeutically to improve muscle looseness, right? So basically the way that it works is I inject it into the muscle and then it helps loosen up whatever joint it is. It works that way, unfortunately, by inducing a little bit of weakness, but I, you know, kind of use the amount, just, I'm aiming for it to be not too much weakness and just enough to improve that range of motion, right? And so it's a rebalancing. The way that I explain it is it's a rebalancing of your muscle tightness and strength, right? So if you've got strong, for instance, muscles that are, you know, if your biceps are really, really strong and tight, I'm going to want to rebalance it so that your triceps on the back of your arm can get some more function and be able to extend your arm. In some cases, less so with stroke, I would say, I do refer for an intrathecal baclofen pump. I would say that's a little bit more common in my patients with multiple sclerosis or spinal cord injury. So I'm not going to talk a lot about that, but I'm happy to take questions about that as well. So what the final thing that I wanted to speak about in this talk is difficulty walking, because that's always been of interest to me, is how to improve patients walking. So a lot of times I'll just watch people walk down the street and I'll think, oh, what kind of problem could be causing that? I don't stare too long though. So I was very interested in walking, and all throughout my training at University of Pittsburgh, I trained with people that were also very interested in walking. And so now I was able to pull together this multidisciplinary gait and bracing clinic. It's at UC Health Westchester. And so it's me along with the physical therapist, orthotist, and you, the family and patient, as well, to figure out, well, what problem are you having with the brace that you have? If you already have a brace, why is it not working for you? Watch you walk, and then watch, kind of different trials. Our orthotist is amazing. She will be able to like saran wrap your foot into a different kind of brace and different kind of shoe if you need to figure out, how do we get this to be more stable, and kind of do these temporary modifications to be able to inform us what kind of changes do we need to make to your brace or give you a brace in the first place. Along with that, we're also taking range of motion measurements and figuring out, well, do we need to treat your spasticity or your calf muscles? And then what kind of things can physical therapy do for you as well? So I have just a very brief clip here. This is actually from our gait clinic. And I just wanted to show you, this is one of our patients who did not have a brace, came into I referred the patient to our clinic. And where did my play button go? So you see the left side is the side that's affected. And I'll just let you watch it. His foot is catching on the ground when he tries to swing it through. He's also, I know that not everybody's an expert at looking at gait, but there's also a lot of like knee hyperextension that's occurring as well. And we care about that because it makes your gait less efficient, and it also can lead to increased knee pain. Lots of reasons we want to treat that. So, so this is kind of an example of where you would be if you came to the gait clinic. And Katie, you can see her in the reflection of the mirror here. She's our orthotist who took this particular video. So, oh, I wanted to go to the next slide. So after meeting with me, the physical therapist, and the orthotist, we'll come up with a plan to give you the optimal kind of bracing that you need. And then Katie will oftentimes meet in her own clinic. And this is kind of where this is after getting the patient a brace. And it's not as much of a long clip that you can see, but I'll just let you see. It helps. This is even before making many adjustments to it, but basically she'll make sure that you get like a custom brace, and then making any kind of adjustments that you need to it to make sure that it optimizes your walking. So that is all that I have for you right now, but I'm really excited to take your questions, and whether it's about something directly that I spoke about in my talk or something else that you think I might be able to answer, I'm happy to take your questions.
Thank you, Dr. Hosseini. That was very informative. We do have some questions for you. Question number 1, I have had several subarachnoid hemorrhages and continue to struggle with daily exhaustion, even though my last rupture was 9 years ago. Do you ever use stimulants such as Ritalin to help with this? Any other strategies for helping with fatigue?
Yes, that is a great question. Yes, there is definitely a role for neurostimulants, although I would say before I would jump to using a neurostimulant, the first thing that I would want to make sure is that you're getting adequate sleep, right? There's many things that can cause fatigue, so ensuring that your sleep is good. So I'll ask questions about your sleep. I want to know what kind of exercise you're doing. And so those are the two things that I would really want to optimize first, in addition to making sure that you've seen your primary care doctor to make sure that there's not other underlying things causing it, like thyroid dysfunction, for instance. Making sure that all those things are taken care of before adding a medicine. So I'm not averse to adding, methylphenidate or Ritalin or amantadine, other kinds of neurostimulants, but I don't want to just mask potential other symptoms with just adding a neurostimulant. So yes, absolutely, neurostimulants can help if all those other things have been addressed. Yeah.
Okay, next question. Who is most appropriate to see for memory and balance problems?
So memory and balance, I would say those are two different areas. So for the memory in particular, usually the starting point is a speech language pathologist. So speech language pathologists do not only focus on speech, they also treat memory impairment, and they also treat swallowing impairment. So it is actually the speech language pathologist. So I would say, start with your physician to get a referral to the speech therapist, and then they can do memory assessments, and they can also help determine if you might need what's called a neuropsychological assessment. The neuropsychological assessment can help figure out, are there other things contributing to your impaired memory? For instance, depression or lack of sleep, right? So those other things could be also contributing to your impaired memory. And then the other question was about the balance. Is that correct?
Yes.
Yeah, so for balance, that would be more of the like physical therapist to work on the balance, but I would recommend seeing a physiatrist if there's other more complicated things contributing to the balance problem that you have. But yeah, definitely start with the speech therapist and then also the physical therapist for the balance.
Okay, next question. My cousin has spasticity on the left side and is on high doses of baclofen. He's worried about living on baclofen long term. Are there any alternatives to baclofen?
Yes, definitely. There are, but without knowing the specific, kind of situation, like why is he on such a high dose? And yeah, there are definitely other alternatives in terms of the oral medicines, right? So there's other oral medicines. There are other, like we discussed, there are other Botox injections that can be used depending on, again, I haven't assessed the person, but depending on where the spasticity is, how diffuse it is. Botox can be used, and then the intrathecal baclofen pump is something that we use if we're limited by how high we can go on the oral baclofen, right? So if baclofen's making someone too sleepy, that might be a case where we would say, and if it's really diffuse spasticity, and especially in the legs, then we might want to try like an intrathecal baclofen pump. But yes, there are other alternatives, and I would suggest that the person discuss it with their doctor about what other alternatives there are. And if that particular person, if the primary care doctor is not comfortable with that, I would recommend referring to a physiatrist who specializes in treating muscle spasticity.
That was our last question. Thank you, Dr. Hosseini, for participating in our program today. We appreciated it very much. It was very good.
Oh, well, you're very welcome. And I'm happy to take, additional questions later if you wanted to send those to me as well.
Okay, thank you.
Thank you.